Welcome, everyone. We are so excited that you're with us again. This is our third learning session for ACE Leadership Collaborative. So just for those that may be new, we are a South Carolina long-term care learning collaborative, and our goal is to strengthen frontline staff retention. The foundation for that is through high leadership performance. This program is funded through the American Rescue Plan Act of 21. It is the Nursing Home and Long-Term Care Facility Strike Team and Infrastructure Project. So we, Constellation Quality, which we serve as the South Carolina QIO in collaboration with the Department of Health. And ACE is just our kind of umbrella for our project. So again, welcome. We're so excited. And I'm going to turn it over to my colleague, Ann Louise. She's got her camera off because she's running the slide deck for us, but she's going to give us a little bit of housekeeping before we get started.
Good afternoon or good morning, depending on where you are, everyone. If you wanted to log in now, you could, and just take a picture, use your camera on your phone, take a picture of the QR code, and you'll see a little yellow a link that'll pop up under the picture, and it'll say poll everywhere, and then you can just press that and you will be automatically directed there. You could also just, if you don't have that capability, you can go to the website that's listed there, www.pollev.com, Alyssa Pichelle 701. And with that, I'm going to turn it back over to Beth.
Great, thank you. And I'm excited to see some new names, and we would love for you to drop in chat the facility that you're with, just so that we can acknowledge you. And again, welcome. We're excited to have you join us today. So for those that have not met the ACE team, my name is Beth Hersher. I just serve as the program manager for the project, and you just met and heard from my colleague, Ann Louise Moran. She is a nurse and one of our QI specialists. She's also a nurse educator, so we're excited to have her with us on the team. And then Ann Louise and I are supporting your faculty, and we're going to turn the program over to in just a moment, David Farrell. So again, welcome on behalf of ACE team. This collaborative launched in April. We're going to run this through October. The virtual piece of it is April through September. October is going to be an in-person celebration. Ann Louise and I will be sending out the save the date very soon. So we will be inviting you for this, what we call an Outcomes Congress, but it's really just a celebration. So that will be coming. The virtual collaborative, again, our goal is to strengthen frontline staff retention. We're bringing you the second Wednesday of the month is a didactic by David, 60-minute Zoom session or a learning session. And then we follow that up in the month on the fourth Wednesday, a brief 30-minute coaching session. So it's intended to be informal so that you can turn your cameras on and talk to one another and share what you're learning through David's didactic sessions. And again, just as a reminder, we love to hear from you. Ann Louise has given you some information on how to drop into chat or just unmute yourself and feel free to answer questions or give feedback, because we want everybody to participate, and an all teach, all learn atmosphere is what we want you to have. And with that, I am going to turn it over to David. David?
Great. Thank you, Beth. So just as a reminder to everybody, we've been working in South Carolina now for a couple of years. And through this process of working with the highest performing nursing homes who performed the best over the course of the pandemic, we've gathered a bundle of their high value interventions that serve them so well in reducing and mitigating COVID outbreaks. But also we found foundational to that was their staff stability and their ability to reduce registry or keep registry out and keep their staff in place during the pandemic. That was truly foundational to their success with infection control. So we've continued with this collaborative, and we continue to share with you specifics around what we found within this bundle of high-value interventions. And today we're going to cover a couple of those pieces. So we're going to look at new hire orientation. We're going to discuss consistent assignment versus rotating assignment from the perspective of staff retention. And we're going to talk about what nursing homes do and what leadership teams do to improve staff attendance and trigger reliability. So let's just cover orientation first. Due to the pandemic, most orientation programs for new hires became pretty boring, heavily reliant on video watching and in rooms alone. And in our second phase of the collaborative, we were working with nursing homes, and we had a director of nursing go through the orientation program because she was recently hired. And through that experience, she said, we need to change our orientation. That was just not a good experience. And we encourage you to do the same, at least annually. Collect data on your orientation program. Collect it by measuring, of course, the turnover rate of your new hires as one data point, but also collect some qualitative data by asking the last 10 new hires specific structured interview questions about the orientation program that they just went through. You really want to get to the root causes of why new hires leave. And oftentimes, a lousy first start, let's just say, can certainly lead to a high percentage of staff leaving within the first month or first couple of months of their stay at your nursing home. So this actually happened in the nursing home that I managed. I'm a nursing home administrator and have been for 35 years here in California. This is, of course, another example, we've covered this before, of the Swiss cheese theory of in this case, an avoidable resignation. When all the holes in a big hunk of Swiss cheese align, those holes tend to cause adverse events when they're lined up perfectly. And in this case, they were. On day one, we were so happy we had hired an RN. So hard to find an RN on the night shift. We had finally found one. The RN arrived at the nursing home at 7:30, like she was told to arrive. At that time, our DSD to greet her and take her into orientation didn't show up till 8:15. Later that morning, as leaders came into the DSD office to interact with the DSD, she never took the time to introduce the new RN to each person that she was interacting with. And the RN, the new RN, obviously felt like she didn't really matter. On day 3, after the 2-day classroom orientation, the new RN was assigned to a frazzled, pretty new LVN who just finished her orientation, and the RN was assigned to learn from the LVN how to do the med pass in their memory care unit. On day 4 of the RN stay at the nursing home, she was asked by the DON when she'll be ready because they're likely going to be short this weekend and they really need her. Day 4 was also spent on an understaffed memory care unit where the LVN doing her orientation was complaining about how she had to deal with a fall and a resident who sustained an injury. On day 5, the new RN called off sick, and then later that day she sent an email and resigned. Just a tragic comedy of errors. What can we do better? Well, what nursing homes who are successfully running orientation programs, like I said, they examine it, they collect data, they ask questions, but they also do some of the basics that you would expect in a good orientation program, such as the administrator and DON spending a considerable amount of time with the orientees on day 1, on their first day in the orientation program. We would expect that the supervisor of the new hire would be focused on introductions and making sure the person felt welcomed, making sure that someone is taking the new hire out to lunch or ensuring that they have lunch for their first couple of days. And coworkers around the new hire would be instructed about the new hire, who they are, where they came from, a little bit about them. Some facilities have a warm welcome with a pizza party on the neighborhood for a new hire. In other words, the facilities that are successful in making someone feel welcome put some effort into it. They put some thought into it. They have a strategy to do it. The other things that we've learned is that the best way for a new hire to settle in is to give them a stable and consistent assignment versus moving them around to try to give them a little bit of all your facility. Stable and consistent assignments of new hires allow them to settle in, allow them to form some relationships with the staff around them. They're much more likely to stay if they have some stability and they're feeling like they're mastering and learning an assignment of residence that they can handle. And as you know, delivering individualized, personalized care to residents requires that staff deeply know the residents, their likes, their dislikes, not superficially know the residents, not know them a little bit, but deeply know them. And that allows for the individualized care. In addition, when you're onboarding for retention, you don't want to have strict rules around 2 days in the classroom and 3 days on the floor and then put them on the schedule. Each new hire is going to require some flexibility in their learning time. Some are ready after 3 days of orientation on the floor. Some might need a week or two. The key is to treat that new hire individually until they settle in and are able to do the job. Just extend the orientation. You've already invested so much in the new hire. You might as well just extend their orientation a little bit if they need it. And then finally, the best performers with the lowest new hire turnover rates have formal mentor programs or CNA peer mentor programs. And that's why, in conjunction to this learning collaborative, we offer free access to NACA's structured formalized peer mentor program for CNAs. CNA peer mentor programs work best when CNAs look at it as a very formal process, as a promotion that comes with a raise. A formal process would reflect that you're selectively picking the CNAs who will be your peer mentors, you're interviewing them, you're giving them a job description, and you're meeting with them regularly to develop their skills. We have Deshaun Davis with us, and he's from Rosecrest, and he has been a part in the key development of the NACA Peer Mentor Program at Rosecrest. So, Deshaun, why don't you share with the group your experience?
Thank you for introducing me, David. Just to kind of get started, when I first got to Rosecrest and I was kind of given this project to spearhead, one of the first things that we had to look into before getting started was what was our goal going, what goals were we going to have, and who would be the right CNA preceptors or mentors to carry that goal. So for us at our facility, something we want to do is smooth the onboarding process, really make it easy to go from, that HR orientation to what it's going to be like on the floor, having that mentor come in, kind of that make the transition a lot easier for them. So that way they don't feel like it's boring or that jarring experience. And like I said as well, having that option of picking the right mentors. So for us, our first preceptor was the lead CNA and staffing coordinator. And we picked her because obviously she had good leadership skills. And one of the more important aspects was picking the right staff members that you know like working for you as well. I guess this is the important thing to say, because you don't want to put your new hires with somebody that you don't know what they're going to say, or anything like that. So that was very important in the selection process. And like David said as well, letting them know, hey, this is going to be, something serious. We're really committed to this, making sure that they're committed to the process as well. And that everybody's firing on all cylinders. And then at that point, to get it implemented, we brought in Christopher, Chris Pierce, our HR manager. He's kind of gonna, you have to have somebody that's gonna oversee it, make sure that all the processes and policies are being followed. And that's kind of his role, where he's already the HR manager, so they already respect him as somebody to, when he comes and lets you know what you should be doing on your job, then they know, okay, well, it's not a joke. I need to step up. So he's kind of taking that role of going into our portal, making sure that the preceptors are inputting all the information, so that way when the administrator or whoever is going to analyze that data, maybe on a quarterly basis, to see, well, where are we losing CNAs, or what are we doing right with the CNAs that we need to continue for new hires. Basically making sure that that's all getting taken care of. So just to keep it kind of short, because we really just kind of started, so there's not much data to kind of go into, but just to kind of keep it formal, the most important thing is having a team that understands that this is going to make it easier for everybody. If you buy into it, it's going to make it easier for your CNAs, because you're not going to nobody's going to be worried about being understaffed. So your CNAs that are already there are more inclined to want to stay. Makes it easier for management. Staffing coordinator, she doesn't have to go call 50 different people to try to get somebody to fill in a shift. And it makes it easier for the HR manager and for, budgeting and all of those things, because, we all know it costs every time you bring a new hire in, and you don't know how long they're going to stay. So it really, there's really some, not sure how to phrase it. There's really needs to be a focus on getting the right people involved on the team, so that way there's the buy-in and they know the goals and everything as the process goes on.
Great, great. Well, I think it sounds like what you're describing is a spillover effect, right? A positive spillover effect. Great. Thank you, Deshawn. Chris, is there anything that you wanted to add?
Yeah, it also starts with, an easy starting point for them, as in you want their name badge ready, you want to get them in the time clock, a small tour of the facility, not a huge tour, just basic needs, like here's the break room, here's the bathrooms, here's where you can order lunch, basic, and get them into the time clock too, because we do use a fingerprint scanner here to punch people in and out. So you want to make sure that these folks are being paid, while they're in the building too. So yeah, I mean, just basic stuff like that. And we also do play an icebreaker game as a new hire orientation. It's called the Skittles game. So we'll have Skittles in the middle, and you close your eyes and you pick a Skittle, and that Skittle color leads to an icebreaker question. So, and people giggle about that too. So, but that's part of the process.
Great. I wanted to ask you, how do you engage staff and keep it from being boring and dry, and great. I'm glad you shared the Skittle idea. Any other things that you do to keep it light, keep them awake?
We've recently implemented a stay interview process.
Oh, yeah, we're gonna
So,
talk about that next in
Yay.
August, so we'll please tune in for that.
okay, so yeah, your 30 day, your 60, 90 annual follow-up with them. We have structured questions. Is there anything
Great.
else that you need? Anything that we're missing and anything that we can improve on? And also with their charting information too, you want to get that stuff over to IT because these new hires are trying to chart and you don't want them logging under somebody else and doing all of that. So just having their login information, time clock, name badge, and bathrooms, break rooms, stuff like that.
I think it's really important what you're saying. It makes a new hire feel like you were prepared for them, that they're important to you, right? When someone shows up and none of those details have been taken care of and people are scrambling, it really sends the opposite message, doesn't it?
Yep.
Yeah. Thank you, Chris. We'll never be successful in reducing new hire turnover if we can't hold on to the folks who've stayed with us. And so, yes, as Chris said, we're going to focus on stay interviews as an extension of orientation, but also with some folks who are reaching certain points of longevity, making sure that people know that they're truly valued. And we'd love to next time hear your how your company takes care of rewarding people who stay with you. During, our interviews of the 8 nursing homes in South Carolina that had the fewest number of COVID cases and deaths and the lowest turnover rates of staff, we met the administrator from NHC Sumter, and that's a very large facility. And she described to us that one of her keys to retaining staff was number one, having a really fun team competition amongst her neighborhoods that's ongoing. Number two, new hires get embedded into a single team, a single unit or neighborhood there at NHC Sumter. And in larger facilities, that really helps new hires. Better for them to feel like they're part of a small corner of your facility to settle in than trying to adjust to a 150 bed facility. And she also describes that this really makes it fun and drives quality improvement efforts at Sumter. Can you touch on the partner engagement program that's been in place since 2006 and how that program really helped probably set the stage for your success over the course of the pandemic?
Well, like I said, we started in 2006 and we've kind of, we've changed it a little bit along the way. Every year we just evaluate, what can we do better? What can we change? What can we do different? It's very much a process where all 3 nursing stations have a team leader, which is the unit manager, and then a co-team leader, which is another department manager. And everybody in the whole facility is on a team, one of the 3 teams, except for myself and Lisa, the director of nursing, because we're the judges. Mm-hmm. Sometimes if we have an AIT, they're the tiebreaker. But generally, Lisa and I pretty much agree. We make our decisions on our own and then compare notes. But basically, the charge of each unit is just to make that unit the best it can be, whatever that means. There's not a lot of rules. It's all about thinking outside the box, doing whatever you can do. The teams do activities, they do educational activities. We set a theme every month, and the theme usually was something that we needed to work on. If we needed to work on falls, or if we needed to work on skin, whatever it was, hydration. We would set that theme and everybody would work towards all their activities would include that theme, and we give prizes every month. And so every month the winning team got a traveling trophy, and at the end of the year, the the team that had the most wins would retire the trophy. And I'm sitting here in between two wonderful nurse managers that I think both have retired the trophy at least 3 times.
But it involves everybody. And I
Right.
think that's where we're, like a family here. We have people in our dietary department and housekeeping, nursing, the business office, all together. It may be hydration. Let's decorate our hydration cart. We're going to go a step further. We're going to bring in snacks and drinks and make it fun and go around with music and things like that. But I think the program really it's not just for the residents, it's for the staff too, to bring this all together. And that helped us a lot during COVID.
And of course, as I mentioned at the outset, assignments really matter, especially for new staff. But assignments and consistent assignments also are well supported in the literature. So nursing homes all over the country, of course, have a choice. You can consistently assign the same caregivers to the same groups of residents in the same neighborhoods pretty much every time they come to work. Or you have a policy that is designed around rotating their assignment, where every month they rotate from one group to the next or from one unit to the next. And that's every 2 weeks or every 30 days. So not sure where your facilities are with this, but these are basically the choices that we have. So it's very difficult to find a research study that shows rotating staff assignment in nursing homes has benefits. There's no studies that support it reduces burnout. There's no studies that support it improves quality of care. On the other hand, there's at least 13 studies that point to consistent assignment as having the benefits that we would hope for. So we focus a lot in healthcare on what the research says. Our federal and state regulations are all driven from research studies. And when we have research studies around HR practices like this, we should pay close attention to their outcomes and also follow the research when it comes to organizational and human resource practices as well. Of course, everything is around implementation, and lots of facilities believe in consistent assignment, but really struggle to implement it. So here's an idea around implementation. Let's say you have a CNA day shift, and each one of your CNAs is basically on a 4-on, 2-off schedule. If you have an even number of caregiver assignments, you structure your monthly schedule to support consistent assignment. And you do so in the following manner. So here's Maria, Jen, and Eddie, 3 CNAs. They work on Unit 1. Maria always has the consistent assignment number 1. She takes care of 8 residents on assignment 1. And as you can see, she's got her 4-on, 2-off schedule there for Maria. Jen always has assignment 2. She also has 8 residents, and assignment 2 is right next to assignment 1. We've sequenced Jennifer's 4-on, 2-off schedule slightly different than Maria's, as you can see. And then Eddie always fills in for Maria or Jen. So these 16 residents in assignments 1 and 2 with perfectly sequenced 4-on, 2-off schedules amongst 3 CNAs enables us to say, yes, we have consistent assignment. We only have basically 3 CNAs signing off on the ADL care of 16 residents. That's really good. It's difficult to do. And the way that you can measure whether or not you have consistent assignment in place, of course, is to count the number of CNA signatures at the end of 30 days on the ADL sheets. If you have 14 signatures or less on your ADLs on a single resident, you're doing a pretty good job of consistent assignment. If 20 to 25 CNAs are signing off on the care of a resident, then you're not doing so well with consistent assignment. As I mentioned, that's how to measure it. And of course, you have to make sure the assignments are fair. Assignments don't necessarily have to be in sequential order of rooms. If CNAs are complaining about the assignments not being fair, and that's why they don't support consistent assignment, the resolution is not rotating assignments. That doesn't make the assignments fair. It just spreads the pain to people periodically. A better way to do it would be to gather the CNAs together and really talk openly and help them make the assignments fair. You may do this by simply allowing them to create a scale around the challenges of delivering care to individualized residents, and then have them go through each resident and assign numeric numbers to how challenging residents are. Doing this allows the staff to engage in a real discussion about the challenging residents, and then enables you to make the adjustments with them to make their assignments fair. But you keep the consistent assignments in place. The solution is not rotating assignment. How do you get people to come to work when they're scheduled, especially now? I mean, things have really changed since the pandemic. But let's talk about triggering staff reliability. Let's talk about absenteeism and how to reduce absenteeism. Because in order to keep your staff, in order to keep your new hires, the best thing you can do is have them come into an environment with stable staffing. If there's a lot of short staff shifts, it tends to scare new hires away.
So when you're talking about reliability, obviously the other side of reliability are call-outs. And as defined, they are unplanned absences, they're no-shows or sick calls. And so what we wanted to do here in the next two slides was use those polling questions and to see how you feel call-outs are, or to extent they're a problem in your organization. And to give you a feel for that, we're giving you a benchmark using the U.S. Bureau of Labor Statistics. They noted absent rates within the healthcare support occupation of using full-time employees is 4.7 in 2023, 4.7%. And that's one of the highest absence rates among all tracked categories. So this percentage could either be manageable for you or devastating, depending on the size of your organization. And so we're going to ask if you want to take that poll, if you had signed in and you have your QR code. So do you track, or are you aware of your facility's monthly call-out rate? It seems everybody is. At your facility, are call-outs a daily occurrence and an inordinate amount of time is spent assuring staff staffing? They're frequent, but you handle them? Or they don't really occur that frequently? And so as we can see, if call-outs are a daily occurrence, that's why we're talking about it now and asking for David to help us with the issue. Thank you,
Ann Louise. So 2020, of course, was an incredible year for absenteeism. I'm sure you all know. It spiked everywhere, and of course, it spiked in April, tremendous rates in April as we all were adjusting to the lockdowns and our kids being out of school. Absenteeism also soared again in December 2020 during the Omicron wave. But it was somewhat in terms of filling shifts. People certainly weren't going on vacations, that's for sure. So the record number of call-offs was somewhat offset by the few vacation days. As part of my work in Massachusetts, I visited numerous nursing homes and sat in break rooms and asked the staff in these facilities two questions. What's it like to work understaffed, and what's it like to work fully staffed? Here's a couple of quotes I captured and have kept with me for years. Some couple of CNAs said these things to me. Mr. Farrell, when we work understaffed, showers are skipped, men don't get shaved, and people are left with empty cups. Another said we deliver rushed, harried, and depersonalized care. Another nursing home CNA simply said, it's hell. When I asked people, what's it like when you're fully staffed, a CNA said to me, well, you can take the time to be more human with the residents, of course, and with each other. Next slide. Why do people call off from work so much? Why do they call off from work so much when they work at nursing homes or in healthcare in general, as the national statistics convey? A good place to start would be to gather with your team and do a root cause analysis about the high absenteeism in your organization. Utilizing a fishbone diagram, just get the conversation going with your team. What's happening here? Is it our systems? Do we have equipment and supply issues that are frustrating people? Are there certain charge nurses that trigger absenteeism? Certain CNAs that might be triggering absenteeism? Is it people or is it the environment? Just really dig in and have a conversation about high absenteeism as the starting point. Of course, as you would expect, absenteeism is highly correlated with social demographics. And we have some unique social demographics amongst the people that we employ. So according to the CDC, women call off slightly more than men every year, 6 days compared to 4 days. But of course, men are women have more responsibilities than men do. We tend to employ many more women than we do men. When it comes to education, individuals with high school diplomas or less call off on average 8 days a year. Individuals who've graduated from college call off on average 3 days a year. We tend to employ a large number of people with high school diplomas or less. When it comes to marital status, people who are married or have never been married call off on average 4 days a year. Those who have been divorced or are separated call off on average 9 days a year. At least 50% of our staff have been divorced. And when it comes to insurance, those who have full health insurance through Kaiser or another insurance plan call off on average 3 days a year. Those who have coverage through Medicaid call off 13 days a year. On average, nursing homes have staff who utilize Medicaid at least 45% of the time. So we're up against great odds here, no doubt. So I've been working on this for years. I've been an administrator for years, obsessed with the schedule, obsessed with preventing understaffed shifts. And at the beginning of my career, I wasn't very successful. I let department heads do their own tracking of their staff's attendance. So that was very hit or miss and wasn't very accurate. When things would get really bad, we would react to it, maybe write some people up, maybe fire someone to get people's attention. And then we generally would forget about absenteeism until it got really bad again. The mistake that I was making early in my career was I was treating absenteeism like it was an individual employee's problem, when in fact, the success with reducing absenteeism relies on managers to treat it like an organizational problem. And the best way to start to treat it like an organizational problem is to make sure that you're accurately capturing the data. And in order to do that, you need a single point person that would track everyone's individual attendance and do it accurately. When you start to collect really good data on who's calling out and the reasons why they're calling out, then you can begin to monitor and report out on the total number of unscheduled call-outs per month. By capturing that number, the total number of unscheduled call-outs per month, it allows you to begin to treat it like an organizational problem. Then, of course, when you start to collect that number, let's say in a 100-bed nursing home, you had 70 call-outs in the month of June. You have a starting point. You can begin to share that number with the staff, right? 70 call-outs in the month of June, and we also had 15 falls in the month of June. And you can begin to make some correlations with the staff between the total number of call-outs and other clinical outcomes of care that you're trying to improve that you know likely has a causal effect. The goal is to reduce the total number of call-outs in your organization, not to punish individuals with the highest number of call-outs. Nothing that I'm going to say today involves writing someone up. I've never really been that successful with turning someone's attendance around by writing them up. I've only been successful in treating this like an organizational problem, but I still, of course, have conversations with individuals who are calling off too much. I just don't do it with a written warning in hand. We're going to focus on the people on the perimeter of the bell curve, of course, those who never call off and those who frequently call off. And by focusing on the people on the perimeter of the bell curve, we're going to influence the people in the middle. See, to reduce the total number of call-outs in a nursing home, you need the employees who don't violate the policy but still call off 7 or 8 times a year. You need to get them down to 3 or 4. If you can get the bulk of people who call off 6, 7, 8, or 9 times a year down to 3, 4, 5 times a year, you're going to reduce the total number. But if you only fire the worst offender who calls off the most, you're likely not going to reduce the total number. It will feel like you did something, but you probably didn't influence the whole organization. You're going to have these critical conversations with certain people more frequently, but you're going to be having these probing conversations about things that are influencing someone's attendance. And of course, when you collect good data, it allows you to drill down into the data, right? So it's not just about the total number of call-outs in a month. It's about, well, which unit had the highest number of call-outs? Which shift on which unit had the highest number of call-outs? When I did this, I learned that on the PM shift, every weekend on Unit 2, we had what essentially was a mean nurse ratchet who worked that shift. And whenever she worked, the CNAs would look at the weekend schedule. They would see that they were assigned to that unit to work with her, and they would call off. And we verified this by asking the CNAs why they were calling off every other weekend on the Station 2 on the PM shift. And they basically said it's Nurse Ratchet. So, that's another really important piece of this data, the drill down effect. Another way to treat call-offs as an organizational problem, in addition to just counting the total number of call-offs, is to begin to measure the percentage of staff with perfect attendance and to measure the percentage of shifts worked understaffed. Start to collect broader organizational data and begin to report out on it, and you will influence it with some of these tips I'm about to provide to you. So often we find that scheduling and staffing practices actually drive up call-outs. Our goal, of course, is to have a very predictable schedule, a stable schedule, but sometimes our own policies create the opposite effect. So, for example, a typical attendance policy in a nursing home basically says, hey, if you have an emergency or if you're sick, you must provide us at least 2 hours notice prior to calling out for your scheduled shift. Alternatively, to request a day off, you must provide at least 30 days notice to request a day off. That's a typical policy that you find in a nursing home. And of course, for many of our low-wage workers, this puts them in an impossible situation, right? They either wait and wait and wait till 2.5 hours before their shift to tell you they can't come in to make it seem like an emergency, even though maybe 5 or 6 days ago they knew they were going to call off because they had something they had to do. Or they will violate the policy if they request the day off 5 days in advance. Now, I know most managers will say, oh no, yeah, but if they came to us 5 days in advance, we would make amends for them. But most staff read the policies and interpret the policies in black and white, and they might be less inclined to come to you 5 days in advance. The key point is that many of the policies that we're working with in a nursing home assume the staff is not a low-wage earner or a working poor adult like we tend to employ. Housekeepers, laundry aides, dietary aides, CNAs. Our policies tend to assume everybody's middle class or above. And this attendance policy is the biggest culprit in that. So we want a more predictable schedule. A better approach with the policy would to be tell the staff, hey, you're adults. We trust you. Things come up, things happen. Even in our world, we get sick. We can't give 30-day notice, or we can't, let you know that we have to have tomorrow off. Things happen. But provide us as much time as you can. I mean, even if it's a Friday afternoon and you're not coming in Saturday morning, tell us on Friday afternoon. Don't wait till 5:30 in the morning on Saturday morning to say you can't come in. In other words, give us as much notice as you can to give us the best chance of filling your shift if you can't work. But you're an adult and we trust what you say. And that's what a no-fault attendance policy is. A no-fault attendance policy is simply this. If someone calls out for any reason, they couldn't come to work on their scheduled shift, it counts as one. There's no qualifying if the absence is legitimate or not. No more requesting physician notes. This really takes managers out of that uncomfortable position of trying to determine if someone's telling the truth. You don't want to be in that position as a manager, and you don't have to be if you adopt a no-fault attendance policy. It's not a lenient policy. It doesn't mean that you're not going to talk to people who call out too much and have a conversation. You're just not going to make them justify the reason by lying to you in order to be in alignment with the policy. Just yesterday, I was in a nursing home, and right next to the time clock was a big new memo from the administrator. And it reminded the staff that if they're going to call out sick, they must call out at least 2 hours in advance. That was point number one. Point number two, right below it, was to tell the staff, and by the way, if you call out sick, we reserve the right to question the legitimacy of your excuse. We reserve the right to request you get a physician's note, and we reserve the right to not pay you if we think you're not telling the truth. I'm here to tell you that memo will not improve attendance. It will have the opposite effect, as it basically tells the staff, we're in control, you're not. And the truth is, the staff are absolutely in control here. They're in control. They will come in when they want to. You can create the conditions for them to want to come in, but it's truly in their control. I used to always share with my staff the data that I'm sharing and encouraging you to collect, total number of call-offs, percentage of shifts worked understaffed, so they know I care, so they know I'm working on it. That alone increased attendance because they knew it was a focal point in a discussion at every general staff meeting. I used to also share this with them. I'd talk to them about perfectly staffed days and our goal of having the highest number of perfectly staffed days. And we would talk about if we can string together enough perfectly staffed days, our residents, the quality of our care is going to really be enhanced. So I encourage you to set these far-reaching goals with your staff when it comes to attendance, and talk to them about what a perfectly staffed day looks like in your organization. Provide feedback, set the example, make sure your department heads have good attendance, make sure that everyone on your leadership team is setting the example. Recognize people with good attendance, but understand that you're probably not going to, the recognition you provide to people with perfect attendance doesn't really influence their attendance. Usually your staff who have perfect attendance have always had perfect attendance, regardless of who works there and who's the leadership team there. The key is you just want to recognize them so everybody sees that you're calling them out as individuals who are very reliable. And usually your people who have good attendance are also pretty good performers as well. You certainly want to regularly give your staff their own attendance record so that they can see it. On a quarterly basis, I recommend that you share the attendance records of each individual employee so that they can see their own attendance record. You might include a letter with each attendance record. For people with perfect attendance, you'd be giving them a glowing letter of praise. For individuals with so-so attendance, you would thank them for their reliability, encourage them to do better next quarter. And for those with marginal attendance, you might write a letter saying, hey, is there anything that we can do? Looks like there's some barriers to you coming to work as scheduled. Come and see me. I'd love to talk to you. So make sure that staff see the attendance records that you're keeping on them. You're the only one keeping their attendance. They're not keeping their own attendance. So make sure that they see their attendance records. And then provide feedback consistently. What I would do is I would ask my staffing coordinator, hey, can you make me 2 lists? One list, give me a list of everybody with 1 call out or less in the last 6 months. Give me another list of the staff who've had 6 or more call offs in the last 6 months. And with these 2 lists at hand, I'm going to have some conversations with people who are on the list. So these are the outliers, right? So the outliers on the far end who never call off, I'm going to make it a point to see them in the hallway or call them in my office. And I'm going to say, hey, you are so important to us. I was just looking at your attendance record. You didn't call off once in the last 30 days or 6 months, whatever it is. Thank you for being so reliable. We're so appreciative that we can always rely on you. For the people on the other end of the scale, you're also going to have a conversation with them, not with a written warning, but your conversation is going to be generally about not what's wrong with them that's causing them to miss work, but what's happened to them or what's impacted them to cause them to miss work. In both cases, You're just having a conversation, but you're really, encouraging and making sure that your reliable folks know you value their reliability, and you're just having a conversation to learn more about what is impeding someone to get to work when they're scheduled. With the folks struggling to get to work, some of the specific questions you'd ask would be these: are some days harder than others to get here? Is this your second job? If we changed your schedule or reduce the number of days, would that help? Would that increase your reliability? Are there other issues you're facing? How's your relationships with your coworkers and your charge nurses? So just dig deeper with folks who are facing these barriers and see if you can work with them to remove those barriers. And then, of course, when someone calls off and you see them in working after they return from a call off, you really are impacting whether they call off next time by simply saying that you miss them. Hey, John, we missed you yesterday. And I know your residents did too. I understand your son was sick. Is he feeling better? Hey, John, we're just a better place when you're here working, buddy, and we missed you. You when you say things like that after people call off and come back to work, it says you're important, you matter, I noticed, I'm not mad, I'm not blaming, I'm concerned about your son. But this is a very powerful message. And if you can do this fairly consistently, especially with individuals who are obviously having some call outs, just follow up with them in a compassionate way. It can make a big impact on turning them around. Yeah, and then finally, always expect the next call out, right? If you're a 120 bed facility with 130 staff, you should expect a call out every day. Somewhere in the day, you're going to have a call out. If you have 3 to 5, it's too many. There's a system breakdown, something's astray, but expect one a day. So if you expect one a day, just be prepared for it. Certainly call employees who call out compassionately. Hey, I understand you just called out and you said you had a fever and chills, and I see that you're scheduled for the next 4 days. Do you think you'll be able to work, or should I replace you now? That type of call. Get ahead of the individual daily call outs that CNA might have. And then always prepare for that 1 or 2 call out by having a replacement in hand. Some facilities use standby pay to ensure that a CNA will answer the call when they need a replacement. Some have already verified with their on-call people that they can come to work tomorrow, and they make sure that there's a short list of who to call should someone call out. And that, encompasses what I wanted to share with you today. Just more pieces of this mutually reinforcing high value bundle that we learned in South Carolina. We're talking a lot about management practices, financial investments, and HR practices to create staff stability. Okay, back to you, Beth.
David has given you a lot of great suggestions on the call outs and how to track that. We are asking and trying to get some data points around staff retention. I'll be sending that out in a follow-up email, so you'll be able to see that. If you can give that to us, that's great. We are trying to collect some of it just with our polling questions, but we just definitely wanted to share with you that following this call, as I mentioned earlier, we will be having a coaching session. That's going to be just discussion of what you just heard today. So we want you to we'll send out the recording. if you need to refresh yourself. But July 24th will be that 30-minute coaching session where you can bring your questions and ask David, to clarify anything that you heard today, or give us, feedback. We love that. And then August 14 will be our fourth learning session. And then, of course, we'll have that coaching session August 28th. Learning session 4, Wednesday, August the 14th. Just a sneak peek of what you'll be hearing David discuss is, again, as he mentioned, the stay interviews. I will be sending that tool out, or a link for where you can download that on our ACE website. He'll be talking about nurse leader development, and then, of course, rounding out with some recruitment discussion. I think that was it. We want to thank you all for being with us today. Thank you again to Deshawn for your sharing. We certainly appreciate all of that. You know how to get in touch with Ann Louise and myself. Ann Louise is, and I'm sorry, Ann Louise, I kind of went ahead of myself, but she is leading the frontline supervisor support. Many of you are participating in that, but we'll send that out as a reminder if you're not participating. And that's just telling her who the nurse supervisors that you would like to go through that series. She would be happy to help you. I'm leading the CNA preceptor, part of what you heard Deshawn talk about. If you're not participating in that, get in touch with me. I'll help you get enrolled in that. David, thank you. What great information you have given everybody today. And we'll just let you guys go back to doing what you do best, which is serving our elders. Thank you so much.